Namaste, Radhe Radhe, and a very, very warm welcome to everyone to our Friday Health webinar series. We also wish you all a very, very happy Radha Ashtami. Tomorrow we have a wonderful virtual Radha Ashtami celebration, and we look forward to seeing you all in that celebration. Today, we will be having our health webinar series on the topic of kidney transplantation. And presenting this topic will be Dr. Dev M. Desai. Uh, Thank you so much, Dr. Desai, for taking time out of your busy schedule to conduct this very informative webinar. And you know how busy you are on your schedule, but you taking time out to educate our viewers on this important topic. We are very, very grateful to you for doing that. And I also want to take a moment to thank Dr. Bal Khandalwalji for helping us organize these health webinar series. Let me take a moment to welcome and give a brief introduction about Dr. Dev M. Desai. He's an MD, PhD, and FACS. He is the region's distinguished scholar in medical research and professor of surgery, pediatrics, and immunology in the Division of Surgical Transplantation at UT Southwestern Medical Center in Dallas, Texas. Dr. Desai is the surgical director of living donor renal transplantation at UT Southwestern, as well as chief of pediatric transplantation at Children's Medical Center in Dallas. Dr. Desai earned his medical degree at the University of California, San Francisco, where he also earned a doctorate in immunology. He completed a residency in surgery and received advanced training through a fellowship in transplant surgery at Stanford University Medical Center. He is certified by the American Board of Surgery and the American Society of Transplant Surgeons. Dr. Desai conducts translational research in transplantation and gives presentation and lectures around the world on his research. He is also the author of numerous scholarly articles and also serves on the editorial board for many journals and publishing groups. He is a member of several professional organizations. Dr. Desai also serves on the Kidney Transplantation Committee of the United Network of Organ Sharing, which regulates organ allocation policy in the United States. Once again, thank you so much, Dr. Desai, and we welcome you to this forum. I now pass it on to you to do the presentation, after which we will have a Q&A segment.
Namaste. Radhe Radhe, and thank you so much for that very warm and generous introduction. I'd like to thank JKYog and Dr. Khandalwalji for inviting me to give a presentation on kidney transplantation. During the next 45 minutes, I will try to outline for you the demographics and the leading causes of kidney failure in the United States. I'll also try to provide an understanding for what the requirements are for kidney transplantation, as well as the different types of kidney transplantation that is available. Additionally, I will finish by going over some of the more recent results in kidney transplantation outcomes, as well as highlight some of the risks associated with kidney transplantation surgery, as well as kidney transplantation medications. Can I have the slide? Okay, can we put it in slide format? Okay, next slide, please. we'll go on to the next one. Okay, perfect, thank you. So kidney failure is very common in the United States. As you can see from this heat map of the United States, this shows what we call the prevalence of kidney failure. That is the number of patients that have kidney failure per million population. And the very dark shaded brown areas represent over 2,000 patients per million that have kidney failure in the United States. And you can see that disproportionately, there's a higher concentration of kidney failure in rural and lower socioeconomic parts of the country. So you see a lot more of the dark brown in the South, in the very tip of Texas, in the Central Valley of California, as well as in the Midwest. And this is partly due to limited healthcare options for patients who live in these parts of the country. There are also fewer transplant centers located in the rural areas of the United States. Next slide, please. So, if we then look at what we call the incidence of kidney failure, that is the number of patients being diagnosed with kidney failure on a yearly basis, you can see that in 2017, there were roughly 124,000 new cases of kidney failure diagnosed in the United States. And you see in the graph that the rate of kidney failure had been growing for quite some time, up till 2007. And there seemed to be a plateau between 2007 to 2011. However, again, from 2012 to the current day, that trend has again had an uptick. This recent trend implies that the burden of kidney failure in the US continues to rise. And this is partly due to the aging population, as well as the increasing prevalence of obesity and diabetes. Next slide, please. In this next table, this actually really gives you much more detailed information about who in the United States is developing kidney failure. So if you look in the top part, you can see that the majority of patients who are developing kidney failure are in the age group 45 and greater. And that men seem to be disproportionately affected compared to women. Almost 25% more men have developed kidney failure compared to women. And then if we look at race and the incidence of kidney failure, you see that whites have the highest absolute number of new kidney failure diagnoses in 2017. However, if we think about the proportional representation in the population, Blacks represent 13% of the US population. However, they represent 25% of those diagnosed with kidney failure in 2017. And if we look at Asians, which include patients of Indian origin, as well as others from East Asia, that the incidence of kidney failure is pretty proportional to the representation of Asians in the population, roughly about 5 to 6%. So Indians and Asians do not have a higher disproportionate incidence of kidney failure. Next slide, please. Then, the next thing is examining, what are the primary causes of kidney failure? And you can see that diabetes represents half of the new diagnoses of kidney failure in the US back in 2017. And that really hasn't changed up until till today. Hypertension is the second leading cause. And interestingly, if you look at kidney diseases themselves, so that is the glomerulonephritis and cystic kidney disease, so these are diseases of the kidney, that represents 10% of the kidney failure diagnoses. And thus, if you think about diabetes and hypertension, 75% of the causes or cases of new kidney failure in the United States could be preventable, through management of those disease processes. Next slide, please. So the options for patients who develop kidney failure is depicted here on this slide. And you can see that you'll see the term ESRD in my slides. And what that represents, or what it stands for, is end-stage renal disease. So that is synonymous to kidney failure or renal failure. And so the options for patients is really, they can go on to some form of dialysis, so either hemodialysis or peritoneal dialysis, or they can go on to have a transplant before they're reach the need for dialysis. Or, as the arrows show, you can start on dialysis and then receive a transplant. The other option is comfort care, and I think that should be considered in patients who are elderly, who are frail, who have multiple other medical problems and comorbidities. There's nothing wrong with providing comfort care in the setting of kidney failure in patients who have multiple other medical illnesses, because dialysis is not an easy treatment option. Next slide. And just briefly, there are two types of dialysis that are available to patients. The first type is called hemodialysis, and that is where blood is removed from the body either through a catheter that is inserted into a vein, or through a large vein that is created in the arm, through which a needle can be placed and blood can be removed. The blood is then circulated through a machine which cleans the blood, and that blood is then returned to the patient. Hemodialysis has to happen at typically 3 times a week, and each course of dialysis roughly 3 to 4 hours. So that's between 12 to 15 hours that patients have to spend at a dialysis center. More recently, there is the option of what we call home hemodialysis, and that's where patients get hooked up to the dialysis machine at night while they're sleeping. Now, that does take some degree of medical sophistication to be able to run the dialysis machine, to be able to connect the patient to the machine, be able to put a needle into the vein or connect the catheter to the tubing. So it is certainly not for everyone. It's a very small minority of patients that are able to do home hemodialysis. The other option is peritoneal dialysis. And with peritoneal dialysis, that is done at home. But in this situation, a tube, a catheter, is inserted into the patient's abdomen, into what we call the peritoneum, which is where the intestines and the liver and the other abdominal organs reside. That peritoneum, that sac, functions as a membrane. So what happens is fluid is instilled into the abdomen, and through osmosis, waste products circulating in the blood of the intestines and in the peritoneal lining go into the peritoneal fluid that is inserted in the abdomen, and then that peritoneal fluid is then drained out, which then removes the waste products. And this is done multiple times at night through a machine that continuously does this every 20 minutes, inserting fluid and draining fluid. And so this allows patients to stay at home. It allows patients to go to work. It also provides dialysis on a daily basis. So it's much more gentle on the body. But again, you have to have the ability to hook up the catheter to the machine, to hook up the fluid and manage that at home. And not everyone feels comfortable doing that. So again, peritoneal dialysis isn't for everyone. Next slide, please. And so, since we do have a treatment for kidney failure, why consider kidney transplantation? So the reasons to consider kidney transplantation are that dialysis isn't needed, so you don't have to be hooked up to a machine 3 times a week. You don't have to have a tube coming out of your abdomen and being hooked up to a machine every night. Additionally, patients who receive transplants generally have more energy and have better general health. they also lead a more normal life. With kidney failure and dialysis, there generally is restrictions on diet. There's also restrictions on the amount of fluid that patients can take in because the kidneys are not able to get rid of the fluid through urine with kidney failure. So with transplant, patients can be on a regular diet. There's no restrictions on fluids. They can go about their regular daily activities. They can return to work. Many of these patients with kidney failure are not able to work because they're very tired from the kidney failure and the treatment. And they also have the freedom to travel. Because if you're on dialysis and you go to a dialysis center 3 times a week, it's hard to take a week-long vacation away from that center and away from the treatment. Next slide. But the number one reason to consider kidney transplantation is that the risk of dying is 3 times higher if you remain on dialysis compared to patients who receive a kidney transplant. And you can see in this graph that over the last 16 years, patients are doing better on dialysis. The deaths per 1,000 patients has dropped from almost 250 to just about 160. But that's still significantly higher than the 30 deaths per 1,000 patient years that we see with transplantation. So it's a marked difference, and that's probably the number one reason that transplantation is the best treatment for kidney failure. Next slide, please. The other thing to consider is that kidney transplantation actually is less costly. So this graph shows the Medicare expenditure per patient per year. And the reason that I show this Medicare expenditure is that when dialysis was first developed, patient advocates as well as nephrologists and other medical experts and really advocated that the government should pay for dialysis because it was so costly and that patients, even with private insurance, wouldn't be able to afford it. So regardless of age, if one develops kidney failure, you automatically qualify for Medicare. And so this is Medicare tracks the expenditures. And you can see that hemodialysis on a yearly basis costs almost $90,000 a year. However, compare that to transplant, which is roughly about $30,000 a year. In the first 5 years alone, transplant will save Medicare or insurance roughly $200,000. It also adds 3.5 additional years of quality life years per patient. So that is, the patients are living longer. And then this doesn't take into account the impact of work. Patients are able to return to work following transplantation. And so they become productive members of society, are able to better provide for their families. And so that's not even considered in that chart. So, everything says that kidney transplantation is wonderful, and I completely agree, but there is an issue, there is a problem, and that's shown right here. This graph depicts the number of patients that are waiting for a kidney transplant. And, next slide, please. So you can see that from 1988 to 2011, the number of patients that are on the transplant waiting list has increased by 100,000 patients. So, and actually right now in 2020, that waiting list number is up to about 130,000. If you look over that same time period, the number of patients that are getting transplants has also increased, but it's now up to about 19,000 a year in 2019, the year that we have complete data for. The number of kidney donors has also increased, but it's still the growth of number of donors and number of transplant performed clearly has not kept pace, and certainly right now still is not able to keep pace with the number of patients that require kidney transplants. So that creates a problem for us in the transplant community. And I'll talk about how we allocate kidneys to try to be fair to get patients the organs that they need for survival. Next slide, please. So what are the general requirements for transplant eligibility? So first, you have to have a decrease in your kidney function. And the way we evaluate that is through something called glomerular filtration rate. And that's, so once the kidney filtration rate falls below 20 mLs per minute, someone can be evaluated for a kidney transplant. Now, most patients who still have a filtration rate of 20 mLs per minute typically do not require dialysis. They still have enough kidney function that they do not need dialysis. So when the kidney function drops to that level, you can start an evaluation to potentially get a kidney transplant or get on the transplant list. Additionally, patients who are on dialysis automatically can go and apply for kidney transplantation or undergo evaluation. Additionally, patients have to be generally healthy. And what we do is we try to generally assess patients to ensure that their life expectancy is at least 3 years or more. So that is that they don't have any other illness or disease that is going to cut short their lifespan before 3 to 5 years. Because really, as I said, the cost effectiveness of kidney transplantation you start seeing after a couple of years. So to make it cost effective, also to be good stewards of a scarce resource, this kidney, we don't want to necessarily give it to someone that's not going to make the best use of that kidney. So, unfortunately, transplant physicians such as myself are put in an unenviable position to try to, have to make these decisions. Ideally, we would like to give everyone a transplant, regardless of how old they are or what other illnesses that they have, if that's what they want. But we do have to make objective decisions when we look at and evaluate potential transplant recipients. And then the other thing is that the patient has to be referred to a transplant center by a physician, and it's typically by a kidney doctor or a nephrologist who's probably already following that patient. A patient cannot just walk into a transplant center and say that I want to apply for a kidney transplant. They have to be referred, and medical records have to be given to the center to be able to start that evaluation. Next slide, please. So a kidney transplant is not just a procedure. It really is a journey. There are two types of kidney transplants that are performed in general, and that it has to do with where the kidney comes from. There is what we call deceased donor kidney transplants. So that is where somebody passes away from whatever medical cause it could be, such as a stroke or in a car accident, and that patient's family donates that person's organs. The other type of kidney transplant is what we call living donor kidney transplant. And that's where someone who either is related or unrelated to the patient says that, I'm healthy and I want to give that patient one of my kidneys. And then the transplant itself, there's a long process through the evaluation. And even after a transplant and the patient has recovered from surgery, having a transplant requires continuous care. It requires specialized medications to ensure that that transplanted kidney works well. And it also requires patients to have other medications and other other healthcare changes to ensure that they remain in good health and are able to keep that kidney for as long as possible. Next slide, please. So as I mentioned, there are two types of kidney transplants, and this shows some data from the United States. As you can see, about 60% of the kidney transplant recipients receive deceased donor organs. Now, roughly 10,000, compared to about 6,000 living donor kidney transplants. Now, in many parts of the world, including India, the majority of kidney transplants are living donor transplants. It's the exact opposite of the United States. And this is due to many reasons. Some countries have different rules surrounding the definition of death. such that death is only when the heart stops. And at that point, most kidneys are not usable. And so like in Japan and Korea, the majority of kidney transplants are living donor kidney transplants because of how they define death. In India, the majority of majority of kidney transplants are living donor transplants because India does not have a well-established deceased donor network. They don't have the infrastructure to recover kidneys from remote hospitals, transport them to the transplant centers. They don't have a list that encompasses the entire country. So deceased donor transplants do occur, but they occur very locally, and they occur if the donor is at the transplant hospital itself. So the vast majority of transplants in India are living donor transplants, although India is working on developing a national deceased donor network. Next slide, please. So there are some absolute reasons why a patient with kidney failure may not be able to receive a kidney transplant or may not be a transplant candidate. And those are listed here. Some of these are probably quite obvious to everyone. So if you have cancer that is active or being treated, then transplantation is not an option, because actually the medications used after transplantation actually will cause the cancer to grow even more rapidly. So patients with cancer are not candidates. Now, if patients have been cured of their cancer, then they can receive kidney transplants. Patients with advanced lung disease, where they have chronic oxygen requirements, or they have ischemic or coronary heart disease that can't be treated. So heart disease where a stent or bypass cannot correct it, those patients are not candidates. If patients have severe hardening of the arteries, then they may not be candidates either, because the blood flow to that kidney will not be sufficient to allow it to work. Patients who have liver cirrhosis or other end-stage organ disease also are not candidates. And patients that have uncontrolled psychiatric illness are generally not candidates, because they are not going to be able to manage the medications and take care of the kidney. And then lastly, morbid obesity. And we kind of touched on this in the sense that obesity and diabetes and high blood pressure are the leading causes of kidney failure. So if we take a kidney and give it to someone who is morbidly obese, then that transplanted kidney is going to suffer the same fate as that person's native kidneys did. Next slide, please. So the evaluation process, as I mentioned, is a somewhat lengthy process, and it really involves a thorough medical, psychological, and social evaluation. Some of the people that patients see as part of their evaluation process include the transplant surgeon, the transplant kidney doctor or transplant nephrologist. They see a social worker who's going to make sure that the patient has resources, transportation, stable housing, so that they'll be able to care for this transplant afterwards. They'll see a dietitian that will make recommendations on their diet and changes that may need to be made. They'll see a financial counselor who'll go over what the out-of-pocket expenses will be for the transplant, as well as what the monthly prescription medications will cost, what their copays will be. They'll see a transplant coordinator who will do a lot of education, and they'll see a transplant pharmacist who will go over their current medications, as well as go over with the patient the medications that they will be taking after transplant, and they'll go over some of the side effects of those medications, as well as the drug-drug interactions that are possible. And then lastly, if needed, they may also need to see a transplant psychologist if they have severe depression or other psychiatric illness. Next slide, please. There are a certain number of tests that are required for all patients undergoing transplantation. So anyone who is over 50 has to have had a colonoscopy within the past 3 years. They will undergo a chest x-ray to look for any lung diseases, an EKG to make sure that they don't have any heart disease. They will have to see their dentist for dental clearance. And you may be wondering, well, why see a dentist? Well, actually, cavities, a tooth decay, or tooth abscesses actually can spread very quickly into the bloodstream and cause sepsis and death in transplant patients, because transplant patients are not able to fight infection as readily as patients without transplants. And so we want to be sure that if there's anything that we can take care of prior to the transplant that could potentially affect the health of the patient, that we do it before they receive the transplant. So they do have to see a dentist. And in women, if they're age over 40, they have to have had a mammogram within the last year. They have to have a pap smear yearly to screen for cervical cancer. And in men over 50, a prostate antigen blood test to assess for the risk for prostate cancer. Next. Additional required tests include blood type. And the reason that blood type is important is that, the reason that blood type is important is that that is the main requirement that we do in terms of matching. So the recipients can have to receive a kidney from a donor that is of a compatible blood type. And I've listed the 4 blood types there, A, B, O, and AB. And next to it, I've listed the donor blood type that recipient could get. So we have to do the blood type on the recipient. We also do infectious disease testing, such as HIV, hepatitis virus testing, syphilis, tuberculosis, and then a couple of common viruses that CMV and EBV. And the reason we test for those viruses is because once you are infected with that virus always lives in the body and actually can become reactivated following transplantation. Additionally, we check a liver test, cholesterol and lipid panel, blood clotting panel, and then a complete blood count as part of that. Next slide. And then there's a number of tests that we do only if indicated. So in patients that are older, or patients who have a history of heart disease or symptoms of heart disease, they will get an echocardiogram. Some will get a stress test, and even some may require cardiac catheterization to obtain clearance to get listed for a kidney transplant. They will also see a cardiologist as part of that in that case. We have to evaluate the blood vessels in some patients that may have hardening of the arteries. So they may require ultrasounds of their blood vessels or a CAT scan of their abdomen and pelvis, because that's where the kidney will get placed. And then patients who have questionable lung function will undergo formal pulmonary function testing. Next. Once all of that testing is done, then a multidisciplinary committee of physicians, surgeons, kidney doctors, all of the other members of the transplant team that the patient saw, we all will get together and we'll review all of the results. And everyone who's met the patient will give their assessment of the patient. And these are the major things that we will be looking for and discussing when we evaluate a patient. One of the other things that we also assess when we evaluate patients for transplant is the issue of what we call medical non-adherence. That is does the patient have a history or behavior of not following through with prescribed medical treatment? So we will contact the dialysis center if they're on dialysis to see if they missed dialysis sessions, or if they leave dialysis sessions early. We assess for whether the patients are taking medications as prescribed, because non-adherence is one of the leading factors of why transplant patients lose their transplanted organ. And then, we also, if there's active substance abuse, we'll refer patients to appropriate treatment. And then the social financial support is important. The patients have to have transportation. They have to have a support person who's going to help them in the acute period after surgery, as well as medical insurance. Once we approve a patient, we have to send all those records to the insurance company that will then review it, and they will give us clearance that they will pay for the transplant, and the patients will then get placed on the waiting list. Next slide, please. So just briefly, patients get listed with what we call UNOS, or the United Network of Organ Sharing. UNOS is a non-governmental organization that has a contract awarded by the Department of Health and Human Services to manage the United States kidney transplant list, as well as manage how kidneys, deceased donor kidneys, then get allocated. So that is which patient is going to get that particular kidney. So UNOS manages the computers that house all of those lists, and so patients get listed with them. And patients can get listed in one of two statuses. They can be active or they can be inactive. Now, sometimes patients get listed in an inactive status, and that could be if they're sick or if there are some medical problems that come up. And then if those medical problems get treated, then they can be switched back to an active status. Now, the way the kidney transplant waiting list works is that it is solely based on waiting time. That is how long you've been waiting for a kidney or how long you've been on dialysis, whichever is longer. So patients who have already started on dialysis and then get referred for transplant evaluation, well, their waiting time will start from the day of their first dialysis treatment. Patients who are not yet on dialysis who get listed, then their waiting time starts from the day they get put on the waiting list. The average waiting time in the United States for a deceased donor kidney transplant is 5 to 7 years. And it really does depend on where you live. So I'm here in Dallas, Texas. Our average waiting time is roughly about 4.5 to 5 years. But if you live in New York or in California, the waiting times are roughly 7 years. If you live in places such as Kentucky or other locations in the Midwest, Nebraska, the waiting time may be 4 years. And the reason for that is that there are fewer patients on the waiting list at those transplant centers relative to the number of donor kidneys that are available. So as you can see the pattern, in the high population dense areas such as Los Angeles, New York, Boston, waiting times are much higher. Next slide, please. The other thing that that the UNOS computers do is that they then try to match a kidney to the recipient. And there are many factors that go into that ranking and who gets that. And there's really not enough time for me to go over all of those intricate details. But remember, blood type is the first factor. So when a kidney becomes available, the blood type of that kidney is known. And then the UNOS computer only looks at the blood type of the recipients that have a compatible blood type. Then the length of time that the patient's on the waiting list will sort patients. And then the other thing that we do is we try to match donor quality to recipient survival benefit. And so probably the best example I can give for that is that if you have a 25-year-old patient who needs a kidney, he has 50 plus years of survival of life expectancy ahead of him. So it doesn't make sense to give that patient a kidney from a 65-year-old donor. And vice versa, someone who's 70 years old, giving them a kidney from a 20-year-old donor also is not the best utilization of that organ. Now, it's not just age that goes into that algorithm, because that would be age discrimination, but there are other factors that go into it as well. But age of the donor and recipient is also considered in that matching process. And then the last thing is the distance between the recipient and the donor. We try to keep kidneys local or regional, so that way donors, the people who donate organs generally feel better if they know that that kidney is going to help someone in their community. And so for that reason, kidneys generally are distributed regionally versus going across the country. Next slide, please. Yeah, you may have. So as I said, the wait list continues to increase. The number of deceased donors, has not kept suit. So we still have that scarcity. Roughly 35,000 new patients are added to the kidney waiting list each year. That is 96 patients per day. Only 19,000 kidney transplants were performed last year. That is 53 per day. So there are 43 additional patients who get listed every day than the number of patients who get taken off the list. So that's why you can see that that wait list is going to continue to outpace the transplant rate. Roughly 4,000 patients die on the waiting list each year. That is 11 patients per day die while waiting for a kidney transplant. Roughly half of the patients who are 60 years of age or older who are placed on the kidney waiting list will never get a kidney transplant. They will die before they get a transplant. So it is imperative for us to come up with other ways of helping patients who need transplants. And one of the ways that we can do that is through what we call living donation, kidney donation. And there are many benefits for living kidney donation. There is a shorter waiting time, typically 1 to 2 months. Once a patient who needs a transplant identifies a donor, and that donor undergoes an evaluation, and if they are medically suitable to donate, we then can schedule that surgery very quickly. Additionally, kidneys from living donors are also generally higher quality kidneys because the donor is healthy, they haven't died, as well as the preservation time, that is how long the kidney is out from the donor before it is put into the recipient, is much shorter. And this results in higher success rates and improved graft longevity. The other thing is that we can optimize the transplant for when the donor and the recipient are both in their best medical condition. And lastly, there are psychological benefits for both the donor and recipient. Donors feel very good about helping somebody else. Recipients feel very blessed that they had someone who did perform such a selfless act, and they tend to take better care of those kidneys because they know it came from somebody else that they know. So there are a lot of benefits of living donor kidneys. But the main, one of the biggest benefits is that living donor kidneys last longer. The two blue bars represent living donor kidneys, and the green bars represent deceased donor kidneys. And there's there's better matching and less better matching. But in general, the take-home message is that the average lifespan of a living donor kidney is almost twice that of a deceased donor kidney. That is 28 years with that blue bar on the far right compared to 14.2, that green bar in the middle. So, the living donor kidneys generally do last longer, which is better, especially for younger recipients. Next slide, please. Now there's, 4 different types of living donation that can occur. Like I said, we can do living related. So that is between siblings, between parents and children, between aunts, uncles, and nephews. So anyone that's biologically related is called a living related transplant. We can also do living unrelated. So those would be spousal transplants, husband to wife, wife to husband, or a coworker to somebody, or someone that you know from the temple. We also have what we call non-directed living donation. That's where someone feels like they want to help somebody, but they don't know anyone who needs a transplant. So they approach a transplant center and they say, I want to help someone who needs a kidney, and you give it to the person that you think is best suited. So they just donate to an anonymous recipient. And then the other option is what we call paired exchange. So in this example above, or to the right, you can see that Mickey cannot donate to his friend Daisy because they're not compatible. And then Donald cannot donate to Minnie, which is, his, say, spouse. But Donald is actually compatible with Daisy, and Mickey is compatible with Minnie. So what we do is we do a paired exchange, in which case all the surgeries happen on the same day, and Mickey's kidney goes to Minnie and Donald's kidney goes to Daisy. So, donors who couldn't donate to their recipients are now able to donate and help their recipient get transplanted. So that is another option for living donation. In general, living donors have to be 80 to 70 years old. They have to come forward voluntarily, so free of coercion, promises, or payment of any kind. They have to be willing and prepared to undertake the donation process. They have to be in good mental and physical health. They have to have access to long-term medical care. The services related to donation, so that is the evaluation, the surgery, the hospital stay. All of those expenses will be covered by the recipient's insurance. So there is no expense for the donor for this donation process. Next slide, please. Now, some of the requirements to be a kidney donor is that you have to be over 18. So no one under 18 can donate. You have to be mentally, if you're mentally incapable of making an informed decision, you cannot donate. If you have uncontrolled high blood pressure or diabetes, you cannot donate because those are the leading causes of kidney failure. If you have any type of cancer, psychiatric condition, if there's any evidence of coercion or payment, and then obviously any type of kidney disease. Next slide, please. The living donor surgery, as I said, is done on the same day. It's done through a minimally invasive approach. That is through a laparoscopic approach. That is, we make 4 small incisions through which we insert a camera and instruments and do the surgery that way. The donors stay overnight. It's a 1-day hospital stay. Most donors return to driving and light activities in less than a week or so. They return to full activities in 4 weeks, and many return to their jobs as long as it does not require lifting or physical activity within 2 to 4 weeks. Now you might think, well, what happens to the kidney function of the donor? Well, as you can see here, if we remove one of the kidneys, there's a 50% reduction in that filtration rate of the kidney. However, over a month's time period, the remaining kidney, the filtration function will increase in that remaining kidney. So a month after donation, the donor's kidney function is not 50%, but it's actually 70, 80% of what it was. So this really allows the donors to really remain healthy. They don't have to be on any special diets or take any special medications. Next slide, please. Additionally, if you look at survival of donors compared to matched controls, that is, patients that are the same sex, age, height, weight. So this is out of the University of Minnesota, and they looked at almost 3,500 donors. And you can see that the probability of survival for the donors is actually slightly higher than their non-donor matched controls. It's only when you get to about 40 years that the curves get together. So kidney donation does not impact someone's long-term life expectancy. Next slide, please. In terms of the kidney transplant operation for the recipient, the operation is the same, regardless of whether it's a living donor kidney or a deceased donor kidney. Generally, we do not remove the native kidneys. We let them stay in place. The transplant operation takes 2 to 4 hours, and the hospital stay for the transplant recipient is roughly 3 to 5 days. Next slide. This shows a cartoon of kind of where the transplanted kidney occurs. So the transplanted kidney gets placed in what we call the iliac fossa, or the pelvis, that is the lower part of the abdomen. And it can go either on the right or on the left side. And to do a transplant operation, we have to connect 2 blood vessels, an artery that takes blood to the kidney, a vein that drains the blood away from the kidney, and then that yellow tube that says transplanted ureter. That yellow tube is what carries the urine that the kidney produces to the bladder. So those are the 3 connections that we have to make. And then this is a picture of a kidney where the blood flow has been reestablished. So you can see it's nice and pink and healthy looking there. Next slide, please. So there are complications associated with kidney transplant, just like with any other operation. You can have surgical risks such as bleeding or urine leak, or the blood vessels or the ureter becoming narrow from scar tissue. You can have wound complications at the incisions. There can be injury to other blood vessels and nerves in the area of the surgery. There can also be complications related to the function of the kidney. Sometimes kidneys don't work right away after we put them in. The risk of having what we call delayed function is roughly 20%. And we see that more with deceased donor kidneys than with living donor kidneys. Now, what we do is we wait for that kidney to start working. So if a patient does have delayed function, they will do dialysis till the kidney function resumes. There is a condition or a situation in which the kidney never recovers after transplant, and that is called primary non-function. And that risk is roughly 3%. So it is quite rare. However, if that does occur, that transplant kidney has to be removed and the patients go back on the waiting list. Now, they don't lose their position on the waiting list. They maintain their time. if this type of condition occurs. And then, the other risk with transplantation is that there is a risk of getting a disease from the donor, whether it's a living donor or deceased donor. And all donors, regardless of type, undergo evaluations for things such as cancer, infections such as HIV, hepatitis B, C, and other common infections. But that risk is not zero, but it is quite rare, 1 in 7 million to get a disease from the donor themselves. And then there are other complications that can occur after surgery, such as heart attack or stroke in patients that may have some heart disease or narrowing of blood vessels in the brain. Infections are another common complication that can occur. The other thing that people are probably familiar with is a term called transplant rejection. And what that term means is that the patient's own body, their immune system, attacks or recognizes the transplanted organ. And the reason that happens is that our immune system is what fights infection. And the way our immune system works, it recognizes foreign proteins that are on bacteria and viruses. But a kidney, because it's come from somebody else, is going to have different proteins than the patient's own proteins. And the immune system recognizes that and then starts attacking that kidney. Rejection that's not treated will actually cause the kidney to fail. But if we can catch rejection early, we can treat it with stronger medications. Now, the risk of rejection is as long as the patient has the kidney. And what patients have to do is take a 2 to 3 drug regimen that roughly is about $3,000 to $5,000 a month without insurance if you have to pay out of pocket. So it is quite expensive. But these immunosuppressive medications reduce the risk of rejection. Now, these medications do have side effects, such as increasing the risk of infections. Some patients develop hypertension, some may develop diabetes. These medications can increase the risk of cancer because our immune system also is important in cancer detection in the body and treating cancers early. So there is that risk as well. But next slide. Remember, despite all of these risks of transplant that I just went over, transplant patients have 1/3 the risk of dying compared to patients who remain on dialysis. So even with all those surgical risks, transplant patients still do much, much better. Next slide, please. And how quickly is that risk of dying reduced in patients who get transplant? No, back one, please. And actually about 3 months. So you can see the risk of death is 2.84 prior to transplant. Within 106 days of transplant, the risk of death versus the risk of staying on dialysis are equal. And then after that, the risk of death is much lower than those that stay on dialysis. So the risk of death following transplant is much improved very quickly after the surgery itself. Next slide. Now, what is the most common cause of kidney failure following transplantation? So you can see back in 1992, patients lost their kidneys, usually to rejection. But now, since 2010, you see that the risk of patients losing their kidney and returning to dialysis is less than what we call death with a functioning kidney. So that is, patients aren't losing their kidneys from rejection or infections or other complications. Patients are actually dying of other diseases and other causes, and with the kidney still working. So the number one reason that kidneys are lost is because the patient dies, not that the kidney stops working. Next slide. And the number one reason that patients die following kidney transplantation is cardiovascular disease. That is stroke and heart attack, which is still the leading causes of death in the non-transplant patient. Then following that is infection and malignancies, but cardiovascular death is the number one thing. And next slide. You can see that from this slide that the cardiovascular risk of death does drop following kidney transplantation, but it doesn't go down to the risk in the general population, especially in the younger age groups. As you see as you get into the older age cohorts, the risk of death from cardiovascular disease following transplantation almost drops to the risk in patients in age-matched controls. But in younger patients, they still have a slightly higher risk of cardiovascular death. Next slide, please. You would go on, next slide. So to then just summarize, hopefully you've gotten out of this that kidney transplantation is the most cost-effective treatment for kidney failure. And it is a treatment, it is not a cure. Transplanted patients live longer and have a better quality of life. Early transplantation, that is before the requirement for dialysis or within 1 year of dialysis, yields the best results in terms of patient survival. Patients can undergo transplant evaluation when kidney filtration is less than 20 mLs per minute. So you can think of that as about 20% kidney function remaining. And living donor kidney outcomes are superior to deceased donor outcomes. Next slide. The most common cause of transplant loss is death with a functioning transplant. And heart disease, by and far, is the leading cause of death in transplant patients. And immunosuppressants are essential to prevent immunologic loss of the transplant, but the side effects can also lead to potential loss of the transplant. So these medications have to be very carefully managed. Next slide. And I can't finish a talk on transplantation without giving a plug for donation, because donation is really what is critical to making transplant happen. So I would encourage everyone to consider being a living donor if you have a family member or close friend with kidney failure, if you're healthy enough to do so. Also, I encourage everyone to sign up to be a deceased organ donor. All religions support organ donation. There is not a single religion in the world that prohibits organ donation. Donation is compatible with all types of funeral services. You can donate an organ and still have an open casket funeral. So it does not prohibit any cultural or religious services following from donation. And it's easy to do. You can sign up when you renew your driver's license online, or you can sign up with your state's donor registry. The donor registry actually is a legal binding document that says you want to donate. It's sort of like a living will. It's akin to a living will. And then the other thing is, let your family know your wishes that you want to donate when you die. Your family is going to be is going to have a lot of sorrow, grief. They're going to be overwhelmed when someone dies, and they may not think about organ donation. They may not remember whether you wanted to have donate your organs or not. So have that discussion when everyone is healthy and alive, and you can discuss this, and people can get their questions answered and that. And then lastly, these are some additional resources for kidney failure and transplant. So there's a number of websites there, and I will be happy to take questions. Thank you very much.
Thank you. Thank you so much, Dr. Desai. That was a very, very power-packed presentation, a lot of information. And I really didn't know that the transplantation was actually much more affordable than even the dialysis. And the other interesting fact that I personally got out is I was more concerned about the other person who was giving, or in the case of a living donor, what will happen to the person who's actually donating the kidney. And you very beautifully explained that even after letting go of one kidney, the other kidney's function will keep increasing after a month's time. So thank you so much for such a informative session. We do have quite a few number of questions coming in from our YouTube participants. We are running out of time, but I think because of the enthusiasm and the interest from the participants, maybe we will take few questions. So without, thank you so much. So before I get into the question, I want to make a very brief announcement. Tomorrow, as well as day after tomorrow, we have a grand virtual Radhashtami celebration. Please do take advantage of it. Radha Rani is the epitome of divine love, and she is the gracious mother who bestows blessings, and she's the one who can help us cross over this ocean of life and death. So please do take advantage and soak yourself in devotion by participating in this wonderful Radhashtami celebration. So we have one segment happening tomorrow in the evening. It starts from 5 p.m. Central Time. And we have another segment on Sunday as well, the Sunday in the morning. So please do register. You can go to our website, jkyog.org or radhakrishnatemple.net. Alternatively, the website, the exact link is jkyog.org/Radhashtami or radhakrishnatemple.net/Radhashtami. With that, let me move on to the question and answers. So there are quite a few questions related to what are some of the preventions or precautions that we can take to ensure that the kidney is functioning properly and it doesn't stop working. So what is it that we can do ahead of time in order to as a preventive measure to enhance the working of the kidneys?
Yeah, so I think I'll refer back to that early slide where 75% of patients who develop kidney failure do so due to diabetes and high blood pressure. Now, the diabetes is in general type 2 diabetes. So this is diabetes that is acquired later in life. And the primary cause of that is obesity. So, watching your weight is probably one of the biggest things that people can do to not just maintain health of their kidney, but also maintain health of their heart and other organs. And so, eating healthy, balanced diet, exercise, and managing weight are probably, one of the best things that people can do to maintain health of the kidney. The other thing is high blood pressure. Now, high blood pressure, is really quite rampant in throughout the world. There are genetic variables that contribute to high blood pressure. And then, there's what we call essential hypertension, where it's not genetically caused, but we don't know what the cause is. And high blood pressure that is managed with medications will not cause kidney failure. But it is high blood pressure that's not diagnosed or that is not managed appropriately over time will cause kidney failure. So, people should, see their physicians on a yearly basis, their primary care doctor, who's going to check their blood pressure, who's going to check your weight, who will check your blood sugar. Doing that early on and not waiting till you're in your 40s and 50s, where you might have had high blood pressure for 10, 15 years unbeknownst to you. And you've already had, maybe 50% kidney function loss at that point. So it's really managing general health is what's going to manage, and maintain the health of the kidney. The other thing that will always help is, drinking plenty of fluids, drinking plenty of water, not getting dehydrated certainly is good for the kidney. Ensuring that your urine is always sort of a clear to light yellow. You never want it to be dark yellow.
Great. Thank you so much, doctor. So basically, if we ensure that overall our health is maintained, the chances of we having a good kidney is also high. We now move on to the next question. This comes from Raju Kaleji, and his question is, after kidney transplant, what are some of the reasons why the transplant fails? And in some cases, the patient will have to go back to dialysis even after the transplant. So what are the reasons because of which the transplant fails?
Yeah, so there are many causes for the kidney to fail following transplantation. There are certain kidney diseases that can come back and affect the transplanted kidney. So there is what we call recurrent disease. Now that's a very small percentage. The biggest reasons that transplanted kidneys fail are for what we call immunologic reasons, that is from rejection. And there are different types of rejections that can occur. And for some rejections, we don't have very effective treatment mechanisms. So that's probably one of the leading causes of kidney failure is rejection following transplant. And as I said, these anti-rejection medications or the immunosuppressive medications that patients take reduce the risk of rejection, but they don't completely take away the risk. So there is always still a risk of rejection, even in patients who are taking those medications as prescribed. And then other causes, there are infections can cause kidney failure. There are certain infections that affect the kidney specifically. There's a virus called polyoma virus or BK virus that affects the kidney and gets in the kidney tissue and causes it to fail. Sometimes the medications themselves, some of the anti-rejection medications can affect the long-term function of the kidney as well. So, and then, in our younger patients, in our young adults, some of them feel like they don't need those anti-rejection medications and don't take their medications. And so due to sort of non-adherence, we have a lot of organs fail, especially in our teenagers and young adults.
Great. Thank you so much, Doctor. The next question is about kidney stones. And this is coming from Geeta Manakattan Liga. And her question is, if someone has a kidney stone, do we remove the kidney or the stone is rushed and passed through the urea? In most cases, yes, and there's also a surgical process, but we also wanted to know if there is any relationship between having the kidney stone, which is even more common, I believe, and that leading to the failure of kidneys.
Yeah, so kidney stones generally do not lead to kidney failure. So kidney stones, the majority of them will pass without any intervention because they're small. But there are some patients that develop what we call large staghorn calculi, which is very large kidney stones that take up a big part of that the central part of that kidney where the urine collects before it goes down into the ureter. And those stones may require treatments. Usually we try non-invasive treatments where we direct ultrasound waves to the kidney stone itself to break it up. So that does not require any type of surgery or incision. And then those small fragments hopefully will pass. In the rarest cases, we may need to do surgery to remove the stone. But usually we don't need to take the kidney out. Now, patients who have severe kidney disease or severe cases of kidney stones, they could develop some loss of kidney function, but it's very rare that patients develop kidney failure.
Thank you, Doctor. Moving on to the next question by Praveen Shah. And his question is, Doctor, you mentioned live donors recover only 70% function of their kidney. Is this enough function for the rest of the life? Are there any downside to it?
So in general, 70% function is more than sufficient to last someone their entire life. So if that were not the case, we would not be removing kidneys from healthy donors. One of the things I didn't mention, but I'll mention now, is that the team of physicians that evaluates a donor is separate from the team that evaluates and takes care of the transplant patient. So that way there's no physicians aren't torn between helping the recipient and then taking care of the donor. So we have a completely separate team that evaluates the donor, and we look strictly at that donor, at their health and their kidney function before we make that, accept a patient to donate. But 70% of function is more than sufficient. One of the graphs I showed that when we looked at age-matched controls, that the life expectancy was the same for those who've donated versus those who haven't donated. Now, that is not to say that there have not been patients who've donated a kidney that have not, haven't developed kidney failure or required a transplant. That can happen. It is extremely rare. The risk for that is about 1 in 5,000. And usually donors who develop kidney failure themselves after donation, it's usually due to reasons and circumstances that were not predictable at the time that they underwent evaluation. So for example, there are donors who've gotten into car accidents or other type of accidents and have injured their remaining kidney, their one kidney. There are donors who have developed cancer 15, 20 years after donation, and the chemotherapy, that medications that they required to treat that cancer, cause their remaining kidney to fail. So there are patients who have donated kidneys who have developed kidney failure and have required transplant or dialysis, but it's extremely rare, and it's usually due to reasons that were not foreseeable at the time that they donated.
Thank you. Thank you so much, Doctor. With that, we'll take one last question. And that question is about the kidney, identifying the health of the kidney. So is there a test to check our kidney health?
So I take it this is for non-transplant patients, just checking kidney health. So there's a very simple blood test. It's part of what we call the chemistry panel that is done when you get a blood test done. And there's two tests that look at kidney function. That is, one is called the blood urea nitrogen, or BUN for short. And then the other is the creatinine. And so both of those blood urea nitrogen and creatinine are actually waste products that the kidney gets rid of. And so in the blood test, when the blood is drawn, we measure the levels of those waste products. And if the levels of those waste products go high, that suggests the kidney's not working as it should. And so that is a very simple test that can be done in most doctors' offices or laboratories, and the results can generally come back within an hour or two. But that's probably the most common test that is done to give us a quick snapshot of kidney function.
Great. Thank you so much, Doctor. With that, we come to an end to today's segment. Once again, we really appreciate you taking the time and educating all our viewers on this very important topic. And thanks to Dr. Val Kandalwalji as well for arranging this session. Once again, to all our viewers, if you like this webinar, please do like, comment, and subscribe to this channel so that you will be aware of all our upcoming videos. And gentle reminder about the virtual, the phenomenal online Radhashtami celebration. Tomorrow it will be from 5 p.m. to 9 p.m. Central Time. And on Sunday, it will be from 10 a.m. to 1:15 p.m. Central Time. Do not miss it. Swami Mukundananda ji will be giving a beautiful lecture on Path Kirtan. And we also have Swamiji physically do the Radha Rani's Charan Puja, which happens only once a year, and he'll be doing it, and we'll all be able to get the live darshan of the puja, as well as get the blessings of Radha Rani and Sri Krishna with live telecast from the Radha Krishna Temple of Dallas. So we'll look forward to meeting you all at the Radhashtami celebration. Thank you. Radhe Radhe.